Hello, I'm Bill Zoghbi. I'm the Chief of Cardiology here at Houston Methodist, and what a pleasure to have Dr. Jamil Tajik with us today. He just gave grand rounds, and I would urge you to take a look at this grand rounds because really it gives us the latest and the most important thing about mitral valve prolapse. Jamil, what a pleasure having you.
It's been wonderful to be here with you, with friends here, and also to discuss this topic with you.
Well, Jamil, Dr. Tajik does not need any introduction. He is really one of the fathers of echocardiography in this country, and I tweeted about you today.
Oh?
Not to announce only the grand rounds, but I said an MVP is giving grand rounds on MVP.
Okay. Good one, huh?
A great topic. Some controversial issues, particularly
Yes.
certainly to sudden death, not necessarily its incidence, but maybe pathophysiology and all with structure and morphological things and some difficult decisions at times to patients. And I think you put it beautifully, and we have a lot of work to do there.
As always, these are works in progress, different groups, your group, others, overseas, Italian group, very active, and several groups that I know are working,
Yes.
deciphering, who is at risk, and can we detect and prevent a catastrophe in these young people, that have bileaflet mitral prolapse or so-called the Barlow's valve disease.
Do you wait for patients? I mean, obviously, it's a lot of decision making with multiple areas of risk, at least that we know that the sudden death. Do you wait for patients to have a syncopal episode or pre-syncopal episode in the whole armamentarium of things? Obviously, there's disjunction, some remodeling, arrhythmias, short runs of VT. Actually, I'm dealing with such a patient, and it is a difficult one.
It is very difficult because patient symptoms are very sometimes non-specific. They're not there fully, and then you sit down with them and try to decipher, are they having some lightheaded pre-syncopal episodes? But the milieu is so arrhythmogenic that if we start seeing that, but you have to document everything.
Right,
if
exactly.
It's not documented, you can't act in a big way. Medications, yes, but not intervention.
For those patients who go to repair,
Yes.
have you seen, at least in your experience, a significant decrease in arrhythmias afterwards or palpitations?
So our own experience is small. I know at Mayo there's a little larger experience on that, and small series are getting published from many centers on this. And I think by far most will indicate that there is reduction, not total elimination, but reduction of post-op ventricular arrhythmias.
Makes it also a difficult decision whether to put an ICD in these patients or just maybe wait afterwards and see what really happens. It is, we need more data certainly in this area.
To subject someone to open heart surgery is a big operation right there, and patients will accept an ICD before accepting, when they don't have too many symptoms. But ICD discharges are also quite bothersome and can create almost like a post-traumatic syndrome.
Two areas I want you to give your thoughts on. One, we didn't get much chance to talk about it because, as you said, you want to condense 2.5 days into 40 minutes. The entity of quote-unquote cardiomyopathy and mitral valve prolapse that may not be related to severity of mitral regurgitation. So ventricle, and also I would add to it, because I've seen some and I want your large experience on it, is remodeling of the atrium, although MR doesn't look severe.
Yes.
Your thoughts on that?
So I'll answer your second comment first, an observation that I think in this myxomatous mitral valve disease, in addition to the valve and the chordal apparatus, the annulus, as you know, is already dilated, And not only is dilated, there's contractile dysfunction of it. In systole, it expands, paradoxically expands. And the left atrium, a number of these patients I've seen with mild mitral regurgitation, a good sized left atrium. And then we exercise them to see what's happening, cannot explain it. And that stays as part and parcel of a myxomatous valve disease, a dilated left atrium as well.
Yes, yes.
Yeah. And back to the myocardial component, myopathic component, that is something that really needs to be looked into in more detail. Right now, these anecdotal aspects, yeah, a patient has died, has fibrosis, that's one thing, but in living patients, I showed you a couple of examples of LV dysfunction, but one of the patients got pregnant, was postpartum now. Is that contributing to it, or was it pre-existing? It's difficult to decipher. We are checking some genes, as well here to see if there is some insight from genotyping these hearts, these patients, and so forth. I have seen few patients that where you want to expand more, to learn more about it. So really more detailed look is still pending to get us a final answer, the myocardial component.
And the last one, which I want to mention our viewers that it is a difficult one, but I want your thoughts on it, and we've addressed it in the last guideline for native valve regurgitation from the American Society of Echo. Yeah. And we made sure to highlight in this guideline, as opposed to the previous one, that there are issues with late systolic MR of how do you diagnose it, because it's not happening throughout systole. So just looking at a color when it comes late, it doesn't give you the whole story, actually may overemphasize it. How do you assess severity with?
Assess, that is a challenge, and particularly, my colleague Maurice Serrano worked hard on this with several papers that got published to how to only take that component for TVI, that is on CW Doppler, late systolic component, and then measuring PISA at the same timing as well, and so forth. But it's very time consuming. As crude it may sound, is that continuity equation, in these individuals. I still think that is a method that I fall back upon.
Yes, that's what we do too.
Yeah, I fall back upon that.
Volumetric is better than this.
Volumetric aspect, and try to make that as a judgment call.
And the caution of not to use EROA. If you want to use EROA, you have to use the volume of it as opposed to the actual thing, because this is, I think, where we see quite a bit of the misnomers of severe MR, but it's really not severe.
Yeah, so the call gets made severe uniformly because there's a big blast of color in only fraction of cardiac systole.
Exactly.
And systole, this is so big that if you're only interpreting severity based on color flow,
you will be misled.
It's misleading completely.
Jamil, what a pleasure.
Oh, it's my pleasure.
What a pleasure, really. And urge you to watch his Grand Rounds, which was really very informational and just amazing, Jamil. Best of luck.
Thank you. Thanks for the invite.
Great to be
here with you.
Great to have you here.